Hello, everybody, and welcome to a COVID-19 lister webinar. This is episode 10, and we're going to talk about some ICU cases, 3 cases that we have had in our unit. My name is Sandra Gelves Zapata. I'm a consultant general surgeon in Colombia, and I'm a local consultant in intensive care here in the UK. Episode 8 was done by my colleague, Kate Flavin, is a consultant in intensive care medicine at Lister Hospital too. And she basically in that episode explained the management of ARDS. And that's basically what we do with these patients in the unit. Before starting with the cases, thank you very much, DJ and Joe, for organizing this webinar and giving us the opportunity to show the community what we try to do for these patients in our unit. So let's going to start with the cases. So some of the patients' details have been changed to protect their identity, but the clinical cases remains real and remain the same. We haven't changed anything. So our first case is a female in her 50s. So she came to hospital with 1 week of shortness of breath and cough. She originally presented to A&E and self-discharge against medical advice. 4 days later, she came back to A&E with worsening short of breath at home. In A&E, she desaturated on 15 liters and non-revealing mask. We did a trial of CPAP, but she remains hypoxic at 75 to 85%. Depending on the position, she was very, because of her body, so we tried to put her lateral, right and left, but she remained hypoxic, and we decided to intubate her and admit her to the unit. As a past medical history, she had previous BEs, she had high BMI, asthmatic, she had an appendectomy and previous pneumonia with pleurisy, so she had some X-ray changes already. On ICU admission, she was in pressure support CPAP, SATs were 91%, ENFiO2 of 90%. The X-ray showed bilateral patch consolidation, very suspicious of COVID-19. Hemodynamically, she was supported with metronidazole and the blood pressure was just acceptable. Her renal function, we could see start to be compromised. So her baseline creatinine was 70 and on admission it was 107. The electrolytes were fine. We started her on coamoxiclav and doxycycline, thinking super infection of this viral probable case. The white blood count, CRP, and lymphocyte was impaired, as you can see. HB and platelets remain okay. So we have the first X-ray when she came to A&E, so we can see here bilateral patchy consolidations, but actually the bases were clear. A decision for intubation and ventilation. So this is the first X-ray that we had on her in the unit. This is actually very typical ICU X-ray for a patient. So if we go a little bit on that, so for the patient, for the people who are not familiar with this. So we have an X-ray that shows a bilateral kind of middle and lower zone consolidation. We cannot see the costophrenic and cardiophrenic angles very well in both sides. And in the rest of the chest is not clear, so we don't have an X-ray that shows a perfectly clear long fields on the top. So we have an ET tube, the carina. We have a central venous line on the right side, who is sitting in the border between the SVC and the right atrium. And we have an H tube coming down in the midline, passing the diaphragm and sitting under the left diaphragm. So that's a right position. That's basically an X-ray for a patient in ICU. So her COVID swabs came back positive. So she was prone 3 times. It was very difficult intubation. Finally, we got her to wind down a little bit of the oxygen. The pressures were a little bit down too. And we decided to do a tracheostomy on her. Unfortunately, we have a couple of complications post-tracheostomy. She had a tension pneumothorax after tracheostomy. It was very difficult to ventilate. She required ventilation water circle for a while, very high pressures, and I think it was a bar trauma. These could be kind of expected complications. She was asthmatic. This is a tracheostomy, and this patient is a little bit different as a normal tracheostomy that we do in the unit, because we don't do it with the bronchoscope due to the higher risk for aerosol spreading procedures. So she developed a pneumothorax that required 2 chest drain insertions. Her renal function got worse, and the AKI got worse, requiring hemofiltration. And we had a lot of difficulties with sedation on her. So we can see in this X-ray, that was the X-ray post-tracheostomy. So we can see the tracheostomy tube here. Again, NG tube coming down, central line coming down. But we can see very important surgical emphysema, even in the other side, so left side and right side. We still have in the bilateral consolidation, but this surgical emphysema brought the attention. So at this point, the lung was up. So she started to become very difficult to ventilate. The peak pressure started to be very high. The blood pressure started to be compromised. But even that, we got quite good SATs at that point. So we had time to do an X-ray, and that's what we found in the X-ray. So we have, again, still with tracheostomy. We can see here the left lung is down, clear pneumothorax line, lots of, lots of surgical emphysema, left side and right side. We have the central line inserted, and it was actually, we can see properly a pneumomediastinum. So we can see the cardiac side in this. So with this X-ray, we inserted the first chest drain. Technically, it was very difficult because of her high BMI, but we got a chest drain in. The first one, it drained some air, and it was connected to suction, low suction in the wall, and the patient improved. So the SATs came up. She wasn't in a FiO2 of 100% anymore. Still a lot of surgical emphysema, as it was expected, but she was stuck in quite high FiO2, 80%, 90%. So we decided to put a second chest drain, as you can see here. So we can see an apical drain. We can see a basal drain. You can see an NG tube. And with this second chest drain, her lung was up. Again, a lot of surgical emphysema. But actually, after the second drain insertion, the FiO2 came down 80, 70, 60, down to 55%. And the SATs were between 89 and 92% as the target as we want in these patients with COVID pathology. So after this chest drain insertion, her chest problem, her lung problems actually start to be more manageable. So currently, she's week around 3 of admission. The FiO2 is around 35, 45%, with SATs of 91, 92. She doesn't have any chest drains. She's off antibiotics, cardiovascularly unsupported, and she's still sedated with clonidine and winning the sedation. So she required a couple of weeks of hemodialysis, 3 times per week. But at the end, she started to pass urine, she started to clear, the creatinine and the urea plateau at some point, it started to come down. So at the moment, she's off any renal support, which is very good. So this is the first case. We're still working on her. It has been a very slow improvement and a slow progression, but we are getting there. We are very happy at the moment. We are winning the ventilation. She's in minimum support, and it's just try to wake her up in the best possible way to try to win and decarnate it at some point. So we're still working on her. It has been a very challenging case, but we're there. The second case is a male in his late 40s. He attended ED with a 2 weeks history of shortness of breath, fever, diarrhea, and cough. This is one of the first cases that we got in the unit where it was a mix between GI symptoms and respiratory symptoms. On arrival, the stats were around 70% on air and improved to 93% with non-revealing mask, 15 liters. So he was transferred to a medical ward initially. He responded very well. But after a couple of hours, the stats came down on non-revealing mask. He was referred to the ICU team. We went to see him and we decided we need to tube him and bring him to the unit. And that's what we did. Past medical history, nothing. He wasn't in any medication. He was absolutely fit and well. On ICU admission, he was on CPAP with a 502 on 85%, with SATs around 90. People 14, he was getting a lot of PIP. The X-ray showed bilateral ossification. He was off any inotrope support. The renal function was absolutely fine. He was passing urine. He was covered with tazocine. CRP was elevated and he was lymphopenic. HB and platelets were fine. He was single organ failure from the beginning. So this is an X-ray of admission, so we can see bilateral basal consolidations. This was after he was tubed. So we can see, again, just to explain a little bit, by basal consolidations, we have the ET tube right now here. We have the left central line inserted, and we have the NG tube coming down. We have a little bit of a gastric bubble here, and a little bit, I think, with air around the cardiac silent. That was him. His swabs for COVID-19 were positive. He started to improve a bit. We came down in the FiO2 in the first days, but he had like kind of second hit where he became quite septic. The oxygen requirements went up. We changed the antibiotics. Inflammatory markers went up. Procalcitonin was high. And he became generally unwell. After some days, everything started to improve again. And we decided he was a candidate for tracheostomy. The pressures were down, the FiO2 requirements were down too. During the tracheostomy, the patient had an episode of respiratory arrest. It was anatomically challenging tracheostomy. And it needed the tracheostomy to be removed and be intubated again. So he had a couple of cycles of CPR and he recovered ROSC. So he was up after that all the time was tubed. So this is another X-ray when we can see the progression of the disease, bilateral infiltration, actually middle and lower zones. So we can see the ET tube, central line inserted, and the NG tube. This was one of the X-ray that was done while he was still with the tracheostomy before the cardiac arrest, the respiratory arrest and cardiac arrest. So we can see the tracheostomy tube here, central line, NG tube, and bilateral compromise. Those are, and so at some point he became even more unstable. He was prone several times, I will say 8 or 9 times. At some point he got very decompensated and we thought that maybe he could have a PE. So he was brought down to CT scan on FiO2 of 90%. So this was the CT scan. We can see the bilateral consolidation, quite severe, ground glass appearance, the the minimal areas that he had aerated, it was in a very bad quality, and you can see the bronchogram in these parts, very, very fibrotic and consolidated, almost an irreversible lung damage at the moment. The airway pressures went up to 59. We play a lot with the tidal volumes, we play with the pressure supports, with the PEEPs. The best airway pressure that he had at some point was at 38. We couldn't brought it down less than that, always as a single organ failure. The CTPA was unconclusive, but he was starting on deltaparin, therapeutic dose for PEs and a pulse dose of steroids. This advice was given by the ECMO center at Papua. He wasn't an ECMO candidate because he had been quite a prolonged time intubated, and the compromise, it was too severe. As I say, he was prone several times. The last 2 times that he was prone, we couldn't see any improvement at all. And he wasn't 100% FiO2 for a while. So after maximum medical therapy, talking with a few centers, trying to do as much as we could, he sadly passed away almost 5 weeks after ICU admission. So we really, really did try with him. He was a fit and well gentleman. This is one example of how different one patient behave from another one. You are not expecting that response. In some normal ARDS patients, we don't see this compromise in the lungs. And we think, or we see at the beginning when we start to management with lung protective ventilation and the other measurement from ARDS, that they actually respond. Patient like this one, it was absolutely impossible to bring down the peak pressures. The lungs were very, very stiff, and unfortunately we couldn't do much for him, and he sadly passed away. So this is our second case. Our third case is a female on her mid-60s. So she came to the hospital with a week of history, 10 days of history of nausea, vomiting, loose stools. After that, the respiratory symptoms came. So this is another patient that came initially with GI symptoms and after that developed respiratory symptoms. So it's not the typical COVID-19 symptoms that we saw in the literature. So this came from another part of the story, 2 different things. And so she became short of breath and she was referred to a medical team. In the medical ward, she became hypoxic on 15 liters of non-rebreathing mask. We assessed her and we took the decision that we need to bring her to ICU for intubation and ventilation. As a past medical history, she was asthmatic, hypertensive, she didn't have any allergies. On the admission, she was in the FiO2 65% with PEEP of 10, and SATs were actually very good, 97%. The X-ray showed bilateral middle zone pacification, very keeping on a COVID-19, the typical X-ray we have on her. Hemodynamically, she was supported with a little bit of noradrenaline. Renal function were fine. She was covered with tazocine, high CRP, and she was lymphopenic. HB and platelets were fine. So we found an X-ray a year before this admission. As you can see, maybe hyperaeration of the lungs, and that's it. She doesn't have anything else major that we could see. This is her X-ray on admission after intubation. So we can see the bilateral patchy ossifications that she had. Again, ET tube coming to the carina, central line inserted, and NG coming down. If you have a little bit of faith, the NG is there. So her initial swabs came as indeterminate, and the second 2 swabs. So we have 2 initial swabs indeterminate for COVID-19. And 2 consecutive swabs were negative. But she was behaving as a patient with COVID-19, and we decided to treat her as that. Once the FiO2 reached 65%, and the SATs were just borderline, like 88%, we decided to prone her. It was an early proning, and she just required 1 event, just 1 proning, that was it. She improved with that proning. The oxygen requirements came down from 65 initially to 40, 35%. we unprone her and start to wean her down. She was very, very weak, and it was a very difficult sedation weaning. So we decided to tracheostomize her. She was off antibiotics at some point. She was improving. So this is the X-ray, the X-rays before the tracheostomy. So she got worse, obviously, before she started to get better. Again, if we go to the AT tube, central line, and NG tube, same as here. ET tube, central line, quite low. Another one here, I think it was a line change at that point. And NG. So the tracheostomy was done 10 days after ICU admission. She was decannulated 13 days later. She was very, very weak. So the requirement of oxygen actually were not high at some point, but she was extremely weak. After the cannulation, she was discharged from ICU 2 days after the cannulation and discharged from hospital under a week after ICU discharge. So this was a very nice case where we could see that even if a patient, the swabs were negative, we treat her as a COVID positive. And she progressed really, really well. And this is one of our happy cases where the patient went home. This is one of her x-rays, one of her last actually x-rays before she left the unit. So we could see in comparison with the previous one, we can see the really, really dense ossifications. And basically, all of that was clearing up very nicely. So those are our 3 cases. And I hope you enjoyed it. And we have a variety of patients, and we are very happy and very proud of what we have achieved with them. Obviously, we had a very sad cases where we couldn't have done more, and unfortunately, we lost these patients. But we have another cases where, like this one, this last case where she went home. And so every day we review protocols, we review new guidelines, experiences, more webinars, more like everything. We are in constant review and studying to try to see what is the best thing that we can do for them. And that's what we are trying to do. All of us, ICU, everybody in the hospital, everybody in the team is really, really trying to do their best, our best, to try to help them. Thank you very much for being here with us. And I really hope you took something for you from these cases and you could see what we have been trying to do for them. So have a good evening. Bye.